Thank you to the moderators and for the invitation to update the SMS regarding Princeton 4. The members of the Princeton 4 committee are pictured here, and it includes an interdisciplinary group including 3 cardiologists and 2 primary care clinicians and a representative from the FDA, Dr. Mark Hirsch. It was dedicated to Dr. Graham Jackson, whose contributions to cardiology and sexual medicine are well noted, and we miss him dearly. So the goals of the meeting and the agenda included an update of the previous 2010 findings and the recommendations, to elaborate the associations between erectile dysfunction and cardiovascular disease, to give a pharmacologic update on the use of PDE5s and alpha blockers and the interactions with nitrates, to review the clinical management algorithms for PDE5 use in men with ED with and without cardiovascular disease, and most importantly, to review the potential cardioprotective effects of PDE5 therapy regarding and optimization of PDE5 therapy in combination, and also to review data on PDE5s in women and recommendations for future practice. You know, it started in 1998, 25 years ago, in response to the sildenafil patient deluge and a lot of men ingesting sildenafil and then experiencing cardiac events. Princeton 1 largely established sex as safe. Sex does increase the rate of the annual baseline risk of MI from 1 to 1.01%, and the risk of sudden death from rigorous sexual activity is 1 per 10,000 patient years. Normal sex, 2 to 3 mets, intense sex is 5 to 6 mets. P1 to P3 developed the recommendations for the clinical management of sexual dysfunction in patients with cardiovascular disease using risk stratification based on the inquiry of ED with exercise tolerance. And P4 continues that, but now includes the use of the atherosclerotic risk calculator, coronary calcium scores, and the role of PDE5 inhibitors. 1/2 to 2/3 of young men who have an MI have no ED, and many men with severe ED never have an MI, but ED severity is strongly linked to coronary artery disease severity and coronary occlusion. ED is a risk marker. It's not a risk factor. There is no causality. We all know about the early studies linking ED to cardiovascular disease. 2 powerful studies cited in Princeton 3, the Inman study and the Chu study, showed that younger men have a marked CVD risk over older men who have erectile dysfunction, and this risk was attenuated with later age and comorbidities. But this previous debate of whether ED is a more powerful predictor in future MI in younger versus older men misses the point, because many men die annually with a heart attack being the first symptom of their condition. Younger men may have only one reliable overt marker of subclinical cardiovascular disease, and that's erectile dysfunction. Banks is one article that we examined completely, and it provides conflicting results, and it says that age is not the driver of risk with erectile dysfunction. The Banks study is much more well-powered with 123,000 individuals versus Chu and Inman, and it also notes mild to moderate erectile dysfunction. This figure is complicated, but does demonstrate the increased relative risk for men with and without known baseline cardiovascular disease and many conditions now associated with erectile dysfunction, including heart block and congestive heart failure. This is the issue of erectile dysfunction and psychological distress. We found many studies that showed that psychogenic ED is a harbinger of increased cardiovascular disease, not dissimilar to vasculogenic ED. And a meta-analysis done in 2017 and 2021 showed significant increased risk of cardiovascular disease. So more research is needed. ED independently predicts cardiovascular events, and this in MESA, and this is an ethically diverse community-based cohort where ED was found to be a significant independent predictor of future hard cardiovascular events. This is the ACC-AHA risk calculator from 2019. As you can see, it utilizes age, it utilizes race, sex, labs, including total cholesterol, HDL cholesterol, systolic blood pressure, presence or absence of diabetes, smoking, and treatment for hypertension. Age is the biggest driver, so that younger men can be missed with this calculator. Older men can be overemphasized with this calculator. There's no family history of coronary artery disease and no ED in this risk calculator. This is the algorithm for the ED workup. What I want you to note about this is this borderline to intermediate risk between 5 and 20%. That's where you utilize coronary artery calcium testing. If coronary calcium scores are 1 to 300, you're going to utilize lifestyle modification and consider preventative cardiology. And I send all of my patients with a CAC score greater than 100 to the preventative cardiologist. This type of scoring is fast, 10 to 15 minutes, very reliable and limited radiation, and very inexpensive and widely accessible. This is the algorithm for the use of the in men with erectile dysfunction and a history of coronary artery disease. This will still utilize the stress test for dynamic exercise testing. I just want to briefly talk about why ED is the PDE5s might be cardioprotective. In this study by Cloner, you see the effect of PDE5s and inhibitors reducing major adverse cardiovascular events by 13% and 25% reduction in mortality. This shows a 55% reduction in overall MACE and mortality with a 49% reduction. These are based on the degree of exposure. These are the studies. I know you can't see these, but based on 20 years of unyielding evidence, the P4 panel determined that ED should be considered an independent marker of cardiovascular disease. Lastly, this was a retrospective observational cohort study released last year that men with a diagnosis of ED without prior MACE, the exposed group was 8,100, unexposed group was 21,000. We see the primary outcome is MACE and the mean follow-up of 37 months. Tadalafil exposure was associated with a lower overall mortality rate of 44%. So all of my men are started on 5 to 10 milligrams of daily tadalafil. Among men who took PDE5 medications, death from heart disease was reduced by 39%, unstable angina 22%, heart failure 17%, and revascularization by 15%. However, it's all based on the severity, and these are retrospective studies. So in conclusion, ED offers a unique opportunity to diagnose and intervene for coronary artery disease. There is definitive evidence linking ED to coronary artery disease. The relationship may extend beyond vascular mechanisms to psychogenic ED. Younger age may not be more cardiovascular predictive, and PDE5 meds may reduce MI, stroke, and mortality. Most patients with stable coronary artery disease do not need nitrates. And with that, I'll pass off to Dr. Kim.
Wow, that was amazing. I was surprised you actually managed to get through all that data in such a short period of time. So we're moving from the land of lush Pennsylvania, where there's lots of data, 20 years of unyielding data, to the land of not that much data. So we're in Scottsdale now, not too many trees here. But nevertheless, the committee did feel that it was quite important to survey the experience of PDE5 inhibitors in women. And often you get this question, right? PDE5 inhibitors don't work in women. Well, do they? And where does that impression come from? And it actually comes from these initial studies way back in the early 2000s, where they did lots of clinical, well, not lots, but several larger clinical trials with sildenafil in women. And if you actually look at these trials carefully, the problem with them is that it was a mixed bag, right? They were women not necessarily diagnosed with female sexual arousal disorder, okay, primarily. And if you look and see that less than half, 48% of the participants in those trials identified FSAD as their primary presenting problem, okay? And so that is a problem. And so more recent studies, when you look at meta-analyses, and this is 14 placebo-controlled studies, smaller in size, but nevertheless in aggregate, you can see that PDE5 inhibitors cause statistically significant improvements in sexual arousal in these women. Okay? PDE5 inhibitors also have been shown to improve overall sexual function in premenopausal women treated with SSRIs. And then if you look at expanding that beyond sexual medicine, looking at individuals with pulmonary arterial hypertension, which is an FDA-approved indication, individuals with Raynaud's phenomenon, preeclampsia, infertility, fetal growth restriction, these are all conditions where increased perfusion helps. So here's a very quick summary and overview, the impact in FSD, okay, and the impact PDE5 inhibitors have positively on orgasm, arousal, and desire, okay, significantly, statistically significant in improvement. You also see statistically significant improvement in pulmonary arterial hypertension, Raynaud's phenomenon, and infertility. Now, PAH and Raynaud's, obviously not 100% women, but you can see that 3/4 of women, roughly, were 3/4 of the participants were women in these trials. Now, it was also important to look at the overview of the safety profile of sildenafil in women, and you can see that the AEs are very similar in nature in terms of the extent and the types as in men. Okay? You can see flushing, headache, rhinitis, and so forth and so on. So very, very similar profiles. And this in the face of very, very high concentrations being used for these other conditions like PAH and Raynaud's. Okay? So up to greater than 3,000 milligrams per day with certain indications. Okay? And that's for both sildenafil and tadalafil. Very, very high doses, and yet still seem to be very safe. Okay? So once again, PAH is the only improved indication in women currently, but current evidence does support considering off-label use of PDE5 inhibitors in women for sexual arousal disorder, as well as for Raynaud's and these other conditions that I've talked about today. Okay? So both Dr. Miner and I, for some reason, are cravateless, but nevertheless, we thank you for your attention. Thank you.